A 12-year-old male presented to the Conservative Dentistry Department Outpatient Clinic, Faculty of Dentistry, Alexandria University in October 2013, complaining of poor aesthetics because of a fused extra tooth attached to his upper front tooth. So upon clinical examination, it appeared microdontia of the left maxillary central incisor because of fusion of the maxillary left central incisor with a supernumerary tooth. The patient was systemically healthy, and the teeth were endodontically and periodontally healthy, and the patient had fair oral hygiene. He had malocclusion that was classified as Class 2 Division 1 and required orthodontic treatment. Previous dental history included extractions of primary teeth and failed orthodontic treatment. Figure 1A shows preoperative frontal view of a maxillary left double tooth where the crown of the maxillary left central incisor is fused with a supernumerary tooth. In Figure 1B, digital periapical radiographs revealed that the two teeth were fused from the crown to the end of the root. From Figure 1C to G, cone beam computed tomography scans, evaluation revealed that two teeth were completely fused with a common root canal system in the coronal to mid-third, then followed by two separate canals. At one level palatally, the teeth appeared to have a common root canal system in the apical 12 mm. In order to pursue orthodontic treatment of the case, a decision was made to retain the maxillary left central incisor following hemisectioning of the fused tooth along with bone graft placement in the resultant socket. The CBCT was valuable in evaluating the clinical condition as well as estimating the amount of required bone substitute. So the treatment plan was discussed with the patient's guardian and as such provided informed written consent according to the requirements of the Institutional Review Board of the Faculty of Dentistry, Alexandria University. The treatment involved a team approach to fix the issue with a 5-year follow-up. So interdisciplinary treatment planning process are the following. First is diagnosis and treatment planning by general dentist or conservative dentist. It begins with a detailed assessment of the fused tooth, considering the patient's overall dental health, the alignment of the teeth, and the aesthetic concerns. They coordinate the involvement of the various specialists. Second is surgical separation by oral surgeon. So, if the treatment plan involves separating the fused tooth, an oral surgeon performs the surgical procedure to carefully split the teeth. This requires precision to avoid damaging the tooth or surrounding tissues. Third is the endodontic treatment by endodontist. So, after the separation, if the pulp nerve of either tooth is exposed or compromised, an endodontist performs a root canal treatment to save the tooth and prevent future infections. Fourth is aesthetic recontouring by the prosthodontist or cosmetic dentist. So once the teeth are separated, the appearance of the teeth may be uneven or unsightly. A prosthodontist or cosmetic dentist reshapes the teeth to improve their appearance, ensuring they blend well with the rest of the smile. Fifth is the orthodontic treatment by orthodontist. The patient may require braces or other orthodontic appliances to correct any misalignment caused by the fused teeth or to address pre-existing issues such as malocclusion. The orthodontist ensures that the teeth align properly after treatment. Sixth is the regenerative approach by periodontist. So in some cases, regenerative procedures like gum grafting or bone regeneration might be needed to support the teeth and maintain healthy surrounding tissues. The periodontist focuses on the long-term stability of the treated area. And lastly, long-term follow-up by all specialists that I have mentioned. So continuous monitoring over 5 years or more is crucial. So all involved specialists track the progress to ensure the teeth remain functional aesthetically pleasing, and stable over time.
In the collaboration, they did a multidisciplinary approach, including endodontic, periodontal, and orthodontic interventions. The management strategy was based on the clinical and radiographic findings and anticipated topography following the dissection of the tweed tooth. In the endodontic therapy, they used a mineral trioxide aggregator, the MTA monoblock. It was selected due to its biocompatible properties, antibacterial and bioinductive abilities, and excellent sealing properties. In the periodontal strategy, it was to obliterate the resultant socket from extraction of the mesodense to promote tissue regeneration and preserve bone around the remaining central incisors. The use of the EMD or the enamel matrix derivative in conjunction with the bone alloplast played a crucial role in orchestrating tissue healing and bone formation. The decision to extract the fused central and the supernumerary tooth would have resulted in the correction of the overjet and stable occlusion results, but it would have been jeopardized the chance to have a normally shaped condition and smile. In the procedures and technique, they used a digital periapical radiographs that revealed two fused teeth with a common root canal system, the coronal to mid-third, and two separate canals. The maxillary left central incisor was retained after hemisection and bone graft placement in the socket, and the CBCT was used to evaluate the clinical condition and estimate the required bone substitute. In the procedures and technique, they used a digital periapical radiographs that revealed two fused teeth with a common root canal system, the coronal to mid-third, and two separate canals. The maxillary left central incisor was retained after hemisection and bone graft placement in the socket, and the CBCT was used to evaluate the clinical condition and estimate the required bone substitute. Then after that, they did a endodontic therapy. It involved preparing access cavities for fused teeth with pulpal communications. The canals were instrumented using a step-back technique and irrigated with a sodium hypochlorite. DDTA was used to remove a smear layer followed by a saline irrigation. The canal was dried up using a sterile paper points. A thick slurry mix of raw root white mineral trioxide aggregate was packed and the supernumerary was irrigated, dried, and filled with a calcium hydroxide. The central incisor access cavity was restored with a composite. 2 months later, the patient underwent a dental procedure involving cemented orthodontic bracket brands, sulcular incisions, and a bronchioperiosteal flap to expose the crestal bone. The crown was sectioned along the groove to avoid injury to the permanent incisors. Periotomes were used to dissect the periodontal ligament attachment. A digital periapical radiograph confirmed the proper orientation of the cuts. The section part was removed, smoothened, and lightly planed with curettes. The socket was rinsed with a sterile saline, and hemostasis was done to prepare for the placement of the endogain or the pref gel. And pref gel was injected onto the section surface, and endogain was mixed with a synthetic bone graft. The flap was repositioned and sutured over the socket. Analgesics, NSAIDs, and antibiotics after this were prescribed. A frenectomy was performed at the 4-month follow-up due to a high frenal attachment in a relation to both central incisors. The patient underwent orthodontic evaluation after surgical endodontic interventions. They were followed up to a year to assess the success of the intervention after a year and 24 months. The patient underwent a modified orthodontic protocol. The procedure involved extraction of the upper first premolars, bonded appliances, retraction of the upper anterior segments, leveling and alignment, crimpable hooks, sliding mechanics, and finishing with stainless steel wires. A removable Holly retainer was used for 1 year after the debanding. So the patient went to a endodontic treatment causing mild sensitivity to cold but quickly resolving after surgery. Healing was complication-free. Conservative treatment was performed via periodontal scaling and curettage. The patient remained asymptomatic and stable for 4 years with only discoloration. After 4 years, a thin labial plate of bone was found and a preapical lesion was developed. So following the termination of the orthodontic retention, a surgical intervention was initiated to address a long, vertical narrow osseous defect on the mesial surface of the maxillary left incisors. Periodontal debridement, root planing, and root end resection were performed. Platelet-rich fibrin membranes were prepared from the patient's venous blood, and the patient showed reduced periodontal probing and attachment loss readings. Graphical radiographs showed bone healing, but mesial crestal bone height did not improve. Regarding with the patient that underwent orthodontic treatment, resulting in a skeletal changes such as reduced discrepancy between maxilla and the mandible, increased facial height, and reduced overthread through maxillary protrusion. protrusion. Sorry. After a year of debonding and retention using the Holly appliances, the patient showed stable occlusion and no morbid changes. However, a year after the second surgery, some relapse was observed.
Here are the detailed results and outcomes. For the clinical improvements in orthodontic treatment, the orthodontic protocol led to significant skeletal and dental changes. The maxillary prognathism was corrected with effective retraction of the upper anterior segment and alignment of the dental arches. The overjet was reduced and normal occlusion was achieved. Post-treatment radiographs indicated stable alignment with no signs of root resorption or blunting. As you can see, the picture shows the panoramic and lateral cephalometric radiographs of the patient 4 years post-operatively, respectively showing good alignment of the teeth with restoration of normal occlusion. In endodontic and periodontal health, the initial endodontic treatment was successful with resolution of post-surgical sensitivity. Despite the presence of a deep periodontal pocket, the periodontal status remained stable with no mobility and bone loss was minimal. The second surgery improved periodontal measurements and healing, though the mesial crestal bone height did not fully recover. For the patient's satisfaction, for the overall outcome, after 5 years, both the patient and his guardian expressed high satisfaction with the treatment, particularly noting improvements in aesthetics and overall function. The only issue reported was minor discoloration of the treated tooth. For the functional and aesthetic results, the patient experienced enhanced dental function and a significant improvement in the smile's appearance, which was a major concern throughout the treatment process. As you can see, this shows the clinical photographs of the patient at different follow-up periods. As you can see, there is a significant improvement in the patient's smile appearance with improved aesthetics and overall function. For the long-term success, the orthodontic results remained stable with normal occlusion and no severe complications. The decision to delay the second surgery for bone and tissue remodeling contributed to a generally positive outcome despite some relapse in spacing. For the maintenance, continuous follow-up ensured the patient remained asymptomatic and stable. The use of platelet-rich fibrin in the second surgical intervention contributed to further periodontal healing and reduced probing depths. In summary, the interdisciplinary approach, integrating orthodontic, endodontic, and periodontal treatments, successfully addressed the complex dental issues, leading to improved function, aesthetics, and patient satisfaction.
The case report by El Bakli et al. Describes the multidisciplinary management of a fused maxillary incisor believed to be a fusion between a permanent central incisor and a supernumerary mesiodens. The approach combined endodontic, periodontal, and orthodontic interventions to address the functional and aesthetic challenges. Over a 5-year follow-up, the protocol demonstrated improved function, stable orthodontic results, and satisfactory patient outcomes. However, some issues, like a deep periodontal pocket and midline diastema, necessitated further surgery. This underscores the value of a multidisciplinary approach and ongoing monitoring in complex dental cases. Similar cases in the literature of Gilberto Sammartino et al., Betul Sanyavus et al., and Tatsuya Akitomo et al. Emphasizes the necessity of a tailored multidisciplinary approach when managing dental fusion cases. Various studies discuss different treatment modalities such as hemisectioning, conservative treatments, and extraoral separation and replantation, depending on the clinical presentation and patient's needs. Endodontic therapy is crucial when there is a shared pulp chamber or communication between root canals, and periodic follow-ups are essential to monitor for complications like root resorption or periodontal deterioration. Other studies reinforce that leaving fused teeth untreated can be an option in less severe cases, but most cases demand some form of surgical, orthodontic, or restorative intervention to address the associated functional and aesthetic concerns. Long-term follow-up is critical for evaluating the stability of treatment outcomes and identifying any need for additional interventions. This case reinforces the necessity for close collaboration among different dental specialties, endodontics, periodontics, and orthodontics in managing complex dental anomalies. Such an approach follows for comprehensive planning and tailored interventions that address the unique challenges presented by each case. The use of materials like mineral trioxide aggregate and enamel matrix derivative is highlighted for their biocompatibility and ability to promote tissue regeneration and periodontal attachment. These materials should be considered in future cases requiring endodontic and periodontal regeneration, especially when extensive tissue remodeling is needed. The case study emphasizes the importance of long-term follow-up to monitor outcomes and adjust treatment plan as needed. The dynamic nature of dental tissue and patient responses means that clinicians must remain flexible, prepared to perform additional procedures such as re-entry surgeries to optimize outcomes. Ensuring patient satisfaction is crucial, as seen in the decision-making process involving the patient and family. Future interdisciplinary care should always incorporate patient preferences and values, balancing ideal clinical results with patient expectations.
In conclusion, an interdisciplinary approach isn't just important, it is essential, especially when dealing with complex dental cases like the management of a fused maxillary incisor and supernumerary tooth in a 12-year-old patient. The treatment required a multifaceted approach involving endodontic therapy, surgical intervention, periodontal management, and orthodontic correction. This collaboration was essential in addressing the challenges posed by the fused tooth, including preserving the tooth function, enhancing the aesthetics, and maintaining the periodontal health. Because dentistry isn't just about treating the teeth, it is about restoring the function, beauty, and confidence that comes with a healthy smile. And when we face intricate cases that challenge both the science and art of dentistry, it's not enough for one specialist to work in isolation. It takes a collaborative effort where each expert brings their unique skills and knowledge to the table, creating a comprehensive treatment plan that addresses every facet of the patient's needs. Now, on the key aspects of the treatment included the accurate diagnosis through a CBCT imaging, which informed the decision to hemisection the fused tooth. Following the surgical separation, the use of biocompatible materials such as the mineral trioxide aggregate and enamel matrix derivative, which played a critical role in promoting tissue regeneration and maintaining the alveolar bone height. Now, the treatment for the orthodontics was employed to correct the malocclusion and ensure stable dental alignment, with regular follow-ups to monitor progress and manage any complications such as the formation of deep periodontal pockets. Over the 5-year follow-up period, The patient experienced significant improvement in both the function and aesthetics, with stable occlusion and high satisfaction reported by both the patient and their guardian. Despite minor challenges, the interdisciplinary approach allowed for a comprehensive and patient-centered treatment plan, demonstrating the value of close collaboration among dental specialists with the precise skill of oral surgeon, the intricate knowledge of an endodontist, the alignment expertise of an orthodontist, and the regenerative techniques of a periodontist. Each specialist has a role, and together they transformed a difficult situation into a successful outcome. The interdisciplinary approach in dentistry, taken as a whole, represents our dedication and commitment to quality and patient-centered care. It's an acknowledgement that dentistry is a constantly changing area and that collaboration produces better results. By combining our abilities, we can innovate and discover answers that a single specialty cannot be able to. And because of this synergy, we are able to confidently take on even the most difficult cases, knowing that we are providing the best care possible for our patients.